this patient, going back to her case, she had declined Len maintenance, which allowed us to use the Len-based backbone for her first relapse management. But clearly, she's demonstrating very high-risk disease with a very short relapse. And Pei, how would you comment on this from a pathology perspective in terms of perhaps giving us a reason for these short remissions in her case?
As you mentioned earlier, that the presence of the deletion 17p, which wasn't detected at the time of the initial diagnosis, now is detected, which can be, this situation can be seen in several situations. So one is that maybe this is a very small clone at the very beginning. So when we do the FISH, because this sensitivity level wasn't high enough, we didn't pick up the clone, but yet after the treatment, maybe this particular clone gets expanded, and now we are able to detect it.
Maybe to that point, I want to clarify that maybe the importance of doing plasma cell-specific FISH testing. Can you briefly comment on that?
Sure, absolutely. So we now have the so-called enrichment. We use magnetic enrichment using 1CD138 to enrich the plasma cells to perform the FISH studies. And this will help to detect the small clones. But still, each lab has different probably threshold or cutoff value. And these small clones may not be necessarily detected even after enrichment.
And how about the SIG-FISH? Some site owners use that as
yeah,
well.
they somehow use also that. That could also be helpful sometimes. Basically, the more enriched the sample is, the higher we are able to detect these kind of abnormal FISH results. Now, in terms of the percentage of the cells, now we have 50%. We have seen literatures reporting a different cutoff in terms of prognostic significance, and you know, I'd like to hear your comments on that myself. In fact, I have read literature. Our experience has been that if the deletion 17p is detected, as I said again, in a broader context of complex cytogenetics, actually these patients do very bad, and they are actually comparable to patients who don't even have 17p deletions but have a complex cytogenetics. And yet, if they are detected in a background of normal conventional karyotype, it means something not as bad as those that have complex cytogenetics. So I think that by detecting this abnormality using FISH, what is the significance? It's pretty high number, 50%. So I'd like to hear your comments as well.
So I think to that point, there's what you're alluding to is clonal burden of the deletion 17p, which, as you alluded to, some cutoffs have been as low as 20% is significant, others as 60%. This goes back to my comment earlier, which is if we're going to talk about risk, we really need to be a phase 3 study with control arms, because otherwise, if you pick, there was actually, the tourmaline study is a good example where when you have the low p53 cutoff of only 20%, it looked like there was superiority. But when you go to higher cutoffs, you lose that benefit. So I think you need the control arms to really show that, to prove that your cutoff is actually doing poorly in the control arm as you would expect, right?
Right, exactly. It needs to be a little bit more standardized. Some institutions do enrichment, others don't. When you report the T53 deletions by FISH, which one are you reporting, right? Exactly. Is it out of total cells you are analyzing versus enriched plasma cell? What's the denominator, so to speak? So it's very important to compare the data to see the significance
with, I think,
of it.
also newer data showing it's not only just the clonal burden, but the allelic burden.
Exactly.
Right? So is it a monoallelic p53 deletion or biallelic? And so I think this is a complex area, and again, speaking to the importance of having control arms in these studies. Right. Are you surprised? Do you think? Do you think you alluded to the possibility of sensitivity failure of the 17p being missed in the initial? What about clonal evolution? Do you think
could be clonal evolution is selected sort of like after the treatment, and these because they are chemo resistant or drug resistant.
Have you seen that a lot?
Yeah,
in
we have
the relapsed refractory setting.
We have seen that the T53 deletion that did not was at least not detected at the beginning, but appear later at the relapse disease. And I think this case highlights the importance of doing FISH for T53 at the follow-up, because you could see it's like a 53 mutation in the AML. It's something that could be evolving. So, just doing a routine what's being detected at the beginning, which is 11, 14, is insufficient.